History taking in pediatrics is quite different from that of the adult because in pediatrics uh, we have content variations from the adult history, and we have different aspects in the pediatric history taking. So we start from prenatal and birth history. This is very important because, like for example, in a neonate, you have to include the neonatal period, the the history of the mother, the prenatal history. We have the developmental history and the feeding history, also the immunization history. They are very important in diagnosing the patient. For example, you have a patient na 28 days old, came in with cough. So you have to ask first if that is less than 28 days old, that is considered a neonate. So you have to ask for the prenatal history, the history of the mother, because some of the diseases in the neonatal period can be attributable to those in the prenatal period also. Like, for example, the mother had illness during the course of pregnancy that is very pertinent to the history of the neonate. We also have immunization history. In pediatrics, we are very particular with the immunization history because sometimes the the choice of antibiotics in pediatrics matters with the history of immunization. Like for example, if the child has not received uh, HIB or HIB na vaccine, we use ampicillin instead of penicillin. So those things are very important. Social history is also important, especially in our adolescents. Later on, I will show you the different tool in assessing adolescent. Environmental history is also important, especially in cases of child abuse. We also have indirect source of clinical information. This is also quite important. Like for example, parents' interpretation of clinical features may affect the accuracy of the data. Sometimes we have parents na denial, or we have parents na may guilt feeling. So different, gina-divert nila ang history. Also have the reliability of the parents' observation varies, and parental behaviors and emotions, as I've said earlier, na there are parents na may guilt feelings. So gina-draw ka towards the true history. Okay, so you have to be pertinent with that, be very particular with that. So in history taking, in all forms of history taking, it always starts with the general data. So the general data pertains to the basic information about the patient, the name of informant, and the reliability. Sa pediatrics, this is very important. Okay? Most of the time, especially if we have the working parents or the busy parents, sometimes ang makuhaan tanang sang tarong na history ang yayay or anybody accompanying the child. Okay? So we start from the general data followed by the chief complaint. So what is a chief complaint? Usually this is a verbatim, no? Verbatim siya. So naano siya, ano ang natabo sa iya, na agindala siya sa hospital. So why was the patient brought to the hospital? It should not be diagnostic terms or names of diseases. So hindi ka magambal na UTI ni sanay, so hindi amo na dapat. You have to dig deeper and use exact words of the informant whenever possible. That's why I said it's verbatim. So next is the history of present illness. It should be presented in chronological order. As I've said earlier, for example, you have a neonate, you have to start from the prenatal history. Prenatal, natal, postnatal history. Also have the maternal and birth history can be incorporated here, as I've mentioned earlier, and history of readmissions if related to the history of present illness. For example, you have a patient with hypokalemic periodic paralysis. You have to ask for previous history of admission of the same disease manifestations. So in the history of present illness, we elaborate on the onset of the disease. Is it acute onset or is it chronic? Because we also have chronic diseases like ang mga leukemia or ang mga vasculitis. They have chronic symptoms and the intensity of symptoms. We also have the aggravating or the relieving factors, which is important in diagnosing the patient. We also ask for medications. And in pediatrics, we are very particular that we always ask for the actual dose. Like for example, doctor nag-take ni siya paracetamol, we always compute for the actual dose. Kaya sometimes we have toxic doses bala na amo na gali nag-cause na nag-encephalopathy ang patient. We also ask for associated symptoms like onset, course, chronology, and the intensity of the associated symptoms. We include always the review of systems because this is also very pertinent. In all other history taking, may it be in adult, in OB-GYN, we always ask for review of systems. So ask only symptoms applicable to the age of the patient. So later on, we will discuss thoroughly how different it is from a newborn, neonate, pediatric, and adolescent. Okay? So in prepubertal female, you have to ask for discharge and itching. So this is actually quite the same, almost the same with that of adults. So you ask for pubertal and adolescent female history of menstrual period, onset, the frequency, the regularity and pain, and the date of the last period. This is especially true when you are suspecting pregnancy, teenage pregnancy, which is very common nowadays. Later on, when you go to the clinics already, or when you will be exposed to the hospitals and you will be asked to deal with a teenager na ginasuspect mo na pregnancy, you have to ask for the last menstrual period. So you ask for the personal history. It's the same with the adult, diba? Sa adult, gina-ask ang mga smoking history. Sa pedia, we start with the gestational history. That's why we are always asking with the prenatal, natal, and postnatal history. So we ask for gestational history, the birth, and neonatal history. So gestational birth and neonatal histories are pertinent for patients less than 2 years of age, and if it is related to the illness for older children. So feeding history is also important, especially in less than 2 years old, because we are dealing with malnutrition most of the time. We always ask for type of feeding, the complementary food, the usual diet. In very meticulous history taking, we compute for the exact caloric intake. That's why we ask for the 24-hour food diary or food recall, because we compute for the actual caloric intake. We also ask for food intolerance, the use of multivitamins and other supplements, and the caregiver. So in childhood and adolescence, this pertains to 2 to 20 years old. We ask for the appetite, for the usual food intake, and the amount per day. That's how meticulous we are. We assess the 5 basic groups and the food likes or dislikes or the feeding difficulties. Sa pedia kasi, especially sa mga neonate, we have a lot of cases of cow's milk allergy or lactose intolerance. That's why it's very important. Developmental history. In young children, 1 to 5 years old, this is very important when we are dealing with developmental disorders like autism spectrum or ADHD. In middle childhood, we ask for school performance and the maturity rating. Later on, we will discuss the specific TMR classification, and also in adolescence. So adolescence, we have the heads. We ask for the home. For each, we have the home and the habits, education, employment, and exercise, accidents, ambition, activities, and history of abuse, may SS pa na siya. The drugs, and sex and suicide. So, if you'll be exposed in the clinics later on, this is important because we have a lot of cases of sexual abuse, of drug addiction. Right now, damo na gani Mobile Legend na addiction bala. So later ma ma-appreciate nyo na when you do the proper history taking and the face. May I ask kung ma-face to face na kamo?
So far, Doc, wala pa announcements.
No announcements yet for
Yes,
the face to face. But all of you are vaccinated naman.
Yes, Doc.
Okay, that's good. Okay, so now let's go to the past illness. So we always dig into contagious diseases, other medical illnesses, and we ask for previous hospitalizations because this could be pertinent to the present history of the patient or history of operations. Like for example, we have patients na post-op adhesions who came in with vomiting. So sometimes gina-refer sa Pedia, especially kung pediatric patient, gina-refer sa Pedia first before the surgery. That's why we ask for kung nag-previous operations because sometimes they present as vomiting also ang mga post-op adhesions. And history of allergy, eczema, and asthma, very, very important kay most of the time. Damo nata siguro with the advent of modern technology man no, na damo gid cases of allergy man and asthma, sometimes acquired asthma na gani. And previous injuries. Immunization history and tuberculin test, especially if the patient had exposure to PTB. We also have in the list of history taking the family history because we also have heredofamilial diseases, which is also present in pediatric patients. The socioeconomic history, the environmental history, important ang socioeconomic history in pediatrics because sometimes we have diseases that are chronic and long-staying diseases. So that's why we ask for the capacity of the patient if they will be compliant to the proposed medical treatment of the patient. Kaya sometimes futile lang man kung if they will tell you na they cannot afford it, or so that we can propose to them other options in the management of the diseases. So we also have environmental history na important man. You ask for the history of exposure to cigarette smoke or other pollutants, garbage disposal, sewage disposal, and the water source. So let's go to pediatric physical examination. So there are just some discrepancies in pediatric physical examination than that of adult, especially true when we are dealing with neonates. Okay, so the objectives of this is to understand how the general approach to the physical examination of the child will be different compared to that of an adult patient. And it will vary according to the age of the patient, as I mentioned earlier. So to observe and demonstrate physical findings unique to the pediatric population and to understand how these findings may change depending upon the age of the child. So we have different physical assessment, different for that in newborn, infant, young, and school-age children, and also the same with that of adolescents. So for the newborn, we have the immediate assessment at birth. So we do Apgar scoring right at birth. We do Apgar scoring. So later on, if hopefully I can see you face to face, no, in the clinics, we will do this sa patient mismo, sa actual patient, because it's somehow siguro do ka difficult sang theoretical kung wala ta siya na perform sa patient mismo. So we do the 1 minute Apgar score. The normal is 8 to 10, 5 to 7. There are some nervous system depression. So the Apgar score consists of the heart rate, the RR, the muscle tone, the reflex, irritability, and the skin color. The 5-minute Apgar score, 8 to 10 is usually the normal, and 0 to 7 is high risk for subsequent CNS and other organ system dysfunction. But it doesn't follow that if na-delayed cry, mayroon siya neurologic sequelae. So it doesn't follow. So to assess the newborn, we have the anthropometric assessment or measurements. And we usually categorize first if the newborn is preterm, term, or postterm. A preterm infant are those less than 37 weeks old. A term infant is between 37 to 42 weeks, and a postterm infant is not more than 42 weeks. By birth weight, we categorize them as extremely low birth weight if they are less than 1,000 grams, very low birth weight if less than 1,500 grams, low birth weight for less than 2,500 grams, and a normal birth weight of more than 2,500. So next is the Ballard scoring. This kung hindi sometimes 'di ba ang LMP is hindi siya approximate lang siya sang age sang patient, sometimes hindi sakto ang LMP na ginahatag ni mother. So if we are not very specific and if wala ultrasound, we always do the Ballard scoring. However, we do the Ballard scoring at birth and after 24 hours. So assessment several hours after birth. So note the newborn's color, the size, the body proportions, the nutritional status, and the posture of the infant, of the neonate, I mean. So you note also for the respirations and movement of the head and extremities, spontaneous motor activity with flexion and extension alternating between the arms and legs, and we observe for brief tremors of the body and extremities during vigorous crying and even at rest. So for the general survey, we have the posture. The normal healthy newborn demonstrates flexion of the legs and arms when supine. So mild cyanosis is normal at birth. So mind you, ang utusap ng baby is not yet normal at the time of birth. The O2 saturation normalizes at around 10 to 15 minutes after birth. So jaundice is common after the second day of life. So the presence of jaundice within the first 24 hours of life suggests a hemolytic process. The most common is ABO incompatibility. That's why if you see a newborn or an infant or a neonate who has jaundice less than 24 hours on onset, you have to think of hemolytic diseases. So the most common is an HBO incompatibility. So for the skin, we note for the vernix caseosa. So the vernix caseosa is, if you see the actual patient, this is the whitish material that you see in the skin of the patient upon birth. You note for the lanugo, the milia or the vesicles, Mongolian spots because this pertains to certain diseases. You note for capillary hemangiomas. Ang hemangiomas are pertinent in patients with vascular disorders, and erythema toxicum. So for the head, we note for the caput and the cephal hematoma. The difference between the two is the caput usually is midline. Midline siya, and it crosses the midline, so pwede siya na both hemispheres. Unlike the cephal hematoma, it is confined usually to one hemisphere, and it doesn't cross the midline. So the anterior and posterior fontanelles should be soft to palpation. The anterior and posterior fontanelles are usually open at birth, and it closes, the anterior fontanelles closes at around 6 to 7 months. The posterior fontanelle, it closes late at around 18 months. So head circumference should be between 33 and 35 centimeters for a full-term infant. So kung more than that, you have to suspect macrocephaly, and you have to associate it with other pertinent findings. So for the eyes, slant and size of the eye should be examined. The pupillary light reflex and a red reflex should be done. So for the ears, low-set ears suggest chromosomal anomaly, and malformed ears are associated with renal abnormalities. Like may mga skin tags na abala sa ears, most of the time, they are associated with renal abnormalities. We also check for the patency of the nose. For the thorax, it's the same. No, for adults, we do inspection, auscultation, palpation, and percussion. In a neonate, we note for nasal flaring and intercostal or subcostal retraction because these are signs of respiratory distress in a neonate. For the cardiovascular system, the manner of evaluating is the same. It just differs in the rate. For example, the normal heart rate for a newborn is between 100 to 160, and like that of adult, which is between 65 to 100. Kung mag 110 to 120 kaya na cardiac rate sa adult, that's already labeled as tachycardia. But in a newborn, if you have a newborn with a heart rate of less than 100, kabahan ka na. Mag-positive pressure ventilation ka na. Okay? And it's the most important thing in a neonate. Diba? Sa adult, usually compression agad because most of the time cardiac ang causes. Unlike sa neonate, most of the time it's the lungs. So you have to ventilate the lungs. So normal blood pressure is dependent on the age of the patient. So in pediatrics, we have a formula for that to calculate for the normal heart rate for specific age group. And later I will show that to you in some of our slides. So transient murmurs are often heard after birth, but the presence of a loud murmur, heart sounds that are difficult to hear or are heard louder on the right side of the chest or central cyanosis suggest a significant cardiac abnormality. So there are cardiac manifestations which are normal to a neonate but not normal to an adult or an adolescent. Like for example, there are transient murmurs in the newborn that resolves within 24 to 48 hours or resolves spontaneously within the first week of life. For the abdomen, in a neonate, the difference is we check for the umbilical cord. It should have 2 arteries and 1 vein. So the liver normally extends 2 centimeters below the costal margin. That's why in a neonate, normally they have large abdomen. They have distended abdomen because gamay pa ang ila na body to accommodate that half size of the liver compared to that of adult. So both kidneys can also be palpated in a newborn. For the CNS, the difference is we check for the baby's posture, alertness, and the level of activity. Usually, a normal term lies folded in the fetal position with the hands closed, whereas a premature baby sprawls out with the hands open. So later, makita nyo na siya sa actual na patient. So, one look, you can see na preterm na siya or a normal term infant na siya. Okay? So a full-term baby who is not demonstrating flexor tone and is lying with the limbs extended may either be floppy or have increased extensor tone like that patients of which are born with meconium aspiration syndrome. So for the CNS, we still do the same for adults. We check for the cranial nerves. And now let's go to the infants. Sa infant, we have the general survey and the vital signs. Kung sa neonate, we do the Ballard scoring. Sa infant, we do the anthropometric measurements or the somatic growth. We check for the length and the weight. But this one, this is used by the CDC, but right now we are following the Z-score. The Z-score for the weight for age and weight for height, height for age. So the vital signs includes the blood pressure, the pulse rate, the respiratory rate, and the temperature. So this, you can see this in your Nelson's textbook on pediatrics. The normal heart rate for age. So it's different in a neonate, in an infant, toddler, preschool, school age, and adolescents. Okay? The normal respiratory rate and the normal heart rate. So we have here a computation of the normal heart rate. So 70 plus age in years times 2. That's the normal systolic pressure. So the diastolic pressure ranges are as follows also. So can you see it in the slides?
Yes, Doc.
So if it's not clear, you can check it on your Nelson's textbook. So we also have the normal temperature. So if you happen to see a neonate or an infant, we always do a temperature regulation in them because they are very sensitive to changes in temperature. So the skin, this is how we assess the skin of the into the digits. So we do the Ortolani and the Barlow's test to check for hip fractures. For the trunk and spine, we observe curvature and integrity. We check for gross defects of the spine. A sacral or pilonidal dimple may indicate a small meningocele or other anomaly. Sometimes mamislook tani siya kung especially kung mga skin tags lang ang makita. But if you go examine closer and you do a thorough physical examination, there are obvious cases of meningocele, but there are isolated cases of meningocele that can be missed out if you don't do a meticulous physical examination. So spina bifida is a defect in the closure of the neural tube that is associated with malformations of the vertebrae and the spinal cord. Sometimes man ang spina bifida can be seen as pinpoint lang siya ng hollow portion. But if you do the ultrasound, it shows the spina bifida. So you will see a lot of cases of this, especially in mothers who are not taking folic acid. So may mga neural tube defects. So for the hips, congenital hip dislocation is usually tested by doing the Ortolani and Barlow maneuver. So for the nervous system, we do the cranial nerve testing. So cranial nerve 1, 2, 3, 4, 5, 6, up to the cranial nerve 12. So actually, it's almost the same with adults. It's just that the manner of testing is the same in infant. Kay sa adult cooperative na naka-operate na si adult. Sa pediatric age group especially in the infants and neonates, okay lang. Ang infants or ang toddlers na nagatantrums, you cannot examine them well. So you have to do, or you have to innovate strategies to get their attention first. So for the nervous system, you have to observe for any abnormal movement or excessive irritability. Sometimes in neonates or in infants, ka-fussy crying, amula na ilan na manifestations, and then later on you will find out na may mga neurologic abnormalities. So for the reflexes, we have the rooting reflex, usually in the neonate, glabellar reflex, grasp reflex, the neck writing reflex, and the Moro reflex. So there's a slide that I will show to you kung how are these reflex being tested and in what age they usually appear. Wait lang ha. Okay, so let's go to the young children. So we are done with the neonate, with the infant. Now let's go to the young children. And then next is the adolescent. So the school-age child, very important, the manner of eliciting the history. So privacy and modesty, explain the procedures and equipment, because sometimes may nagatantrums pa sa amo ni na age group. So, interact with the child during examination. So, dili na di matest ang inyo na mga how you elicit the history, because this is a challenge for the pediatric patients in taking the history. So we do the general survey and we check for the vital signs. Always, and very important, is the anthropometric measurements. We always check for the height and weight of the patient, regardless of if it's a neonate, an infant, a school age, or an adolescent. We always get the anthropometric measurements and the vital signs. So I have mentioned this earlier, the appropriate age, the appropriate heart rate, and respiratory rate for age. So you can screenshot it, or you can check it with your Nelson's textbook. So I mentioned also this earlier, the normal temperature. So for the skin, it's the same with how we examine with the adult. We inspect, we check for a presence of rashes or skin lesions. Oh, sorry. So for the thorax, we check for the cardiac dullness. Usually ginapalpate, tagid na siya, ginapalpate sa, especially sa mga cardiac patients natin. For the cardio, we have the examination of the cardiovascular system. It's almost the same with that of adult. It's just that sa younger patients, usually the cardiac impulse for the genitalia. Oh, sorry. Maybe something is wrong kasi may nagkakatantog diri sa. Anyways, going back. I'm sorry. So for the female, we note for the vaginal discharge. We check for imperforate hymen. We check for the size of the clitoris, the fusion of the labia, and ambiguous genitalia. As I've mentioned earlier, there are cases of ambiguous genitalia, but we cannot label them as female or male unless endocrinologic evaluation has been done. So for male, we check for the position of the urethral orifice, the size of the penis. We check for undescended testes. This is very common. hernia, or hydrocele. So this is the TMR classification for males. We have the stage 1, stage 2, stage 1, pubic hair. So sa pre-adolescents, usually no pubic hair except for the fine body hair. For stage 2, the important thing here is the enlargement of the penis, which is the first sign of puberty in males. Okay? So you have to differentiate the Tanner staging in male. Sino pa di sa inyo ang stage 2? May stage 2 pa? Or may stage 3 pa di sa inyo? The same with the female. So this is the TMR classification sa female. So the most important thing here is usually sa female, ang first sign of puberty is ano sa female ang first sign of puberty? Ano? Breast bud, no? Breast budding. Sa male, enlargement of the penis. Amo na usually ang mga first sign of puberty. So, let's go to the anus and the rectum. We check usually for anal fissures, check for bleeding and constipation, which is almost the same with that of adult. We check for prolapse of the rectal mucosa, especially in cases of pinworm infestation or reinfection where there are prolapse of the rectum. That's why very important. Good. Commonly kasi in pediatrics, there are cases of a lot of constipation, and later on, when they will be evaluated further, may are patients na Hirschsprung's disease. So very important, good, especially kung ang presentation at the time of examination is abdominal pain. Do not miss the rectal examination. So for the musculoskeletal system, the normal young child has increased lumbar concavity and decreased thoracic convexity compared with that of adult, and often a protuberant abdomen. So the range of motion of all joints is greatest in infancy, and the hips is always examined for dislocation because commonly, especially sa mga younger children, no, na nagka-fracture because of they are very restless. For the CNS, we check for sensation, almost the same with that of adult. We also check for the gait, for strength and coordination, and deep tendon reflexes. So there are things in examining the child which is quite very similar with that of adult, especially when are dealing with adolescents. So when we are examining adolescents, we are examining them as adults. It's just that ang difference lang that sa ato na adolescent is we ask for the heads. I've mentioned earlier, no, ang heads ang home, education, sex, drugs, and other pertinent na socio-environmental history. The same also in checking the cranial nerves. Okay, let's go to the adolescent. So I've mentioned earlier that in physical examination and history taking of the adolescents it's quite similar to that of adult. The difference is atong ginhambaltan na heads and other social economic history of the patient. Kasi right now, no, in my private practice, I see a lot of adolescents na may mga mental health issues. Probably because of the lockdowns, grabe ang impact bala sa adolescents. Na for one, ang adolescents can be categorized as early, middle, and late adolescence. So especially in the middle adolescents, these are the stereotypical adolescents, no? Na ara ang peer pressure, and then nag-abot si lockdown, so hindi sila kabalo mag-deal sang how they will deal with the lockdown. So damo gid ako patients sa clinic na amo na usually ang concern hindi katulog, wala poor concentration, daw wala sang Wala bala sang damo gid mga mental health issues. So very vital, especially sa adolescents. Sometimes may times na different ang ila na how they express their feelings ang adolescents unlike that of adults and younger children. So we always go back to the general survey and again anthropometrics and the vital signs. So this is similar to that of adult. Skin, almost the same. We check for acne because may mga prepubertal and pubertal age group na they have hormonal changes na. So the same with that of adult. HENT, we check for the head, eyes, ears, nose, and throat. We check for masses. We check for the patency also. The thorax, the same. We do inspection, palpation, percussion, and auscultation. For the cardio, the same. If we have the murmur, we usually locate the murmur. We categorize the murmur as to the grading of the murmur and the location so that we can give the diagnosis of the patient. Okay, so mas ma-appreciate nyo na siya when we are dealing with actual patients. Kasi actual patients, makita nyo gid how we do about with the cardiovascular examination, kung paano ka meticulous it is in pediatrics and in that of adult. So, I've mentioned, di ba, earlier na the difference man lang usually sa adult and pediatrics are content variants in the history and different age group abi ang pediatrics unlike sa adult na almost pag adult lang gid sila yatanan. Though, ang imo naman sa adults are the comorbid conditions. So the breast, we have the Tanner staging, I've mentioned earlier. Sa abdomen, the same. We do inspection, we do auscultation, palpation, and percussion. Okay, so we've mentioned this sa teenager, no, and sa adolescent, the maturity rating, TMR classification, the Tanner staging. Okay, this is very important, especially sa aging. Okay, for the musculoskeletal, the same with that of the adult. No, the musculoskeletal examination of the adolescent is similar to that of the adult. And pay particular attention to the possibility of scoliosis because damo the cases of scoliosis, especially sa mga middle and high school students. For the CNS, it's the same. We do the mental status examination, we examine the cranial nerves, sensory and motor, deep tendon reflexes, and we do the meningeals. So sa nervous system, the same. We examine the cranial nerves. We do the visual acuity test, the pupillary light reflex, eye movements, hearing, facial strength, and motors. So, how do you check for the sensory system and the deep tendon reflexes? Especially when the patient came in with severe headache, you do meticulous nervous neuro exam. Okay, but not all headaches are neurologic ang cause. Okay, there are some endocrine problems that presents with headache. So, are there any questions? Hindi ko ma-see in yung faces, no? Paano ko na ma-see in yun na faces? So, can somebody do a screenshot? Are there any questions or any pertinent na clarifications?